Oh, wow. We've identified 12 different kind of common ailments, if you will, that we see in our population of people, whether it's on outreach or if you're doing a home visit or, therapy with a client. And so what we had the nurses put together are kind of some red flags for these ailments or conditions, some preventative measures, and then also like what we can do as non-medical staff to keep our clients safe. And so they're going to go through these ailments, and each nurse will present one of the ailments. We'll let them go through their presentation and then jot down questions that you have, and we'll give you space after they're presenting to be able to ask those questions. So we can kind of like, if you have a client that you think of that you're like, oh my God, he has that right now or whatever, we can kind of talk through that too as a group. We have enough time for that. So our first presenter is Maria, and Maria is going to be presenting on foot care. It's all yours, Maria.
Okay, trying to figure this out. Okay, do you guys just see the foot care slide?
We see your notes as well. We see everything.
Oh, let's see. Let me try again. Hold on. Okay, how about now?
Now we see just the foot care.
Okay, great. Okay, so hello everyone, my name is Maria, and I'm a nursing student at UCLA, and today I'm going to be discussing foot care. So a brief overview, and starting with why is foot care so important? So injuries and infections can affect your ability to walk, which is a primary mode of transportation for people experiencing homelessness. Additionally, the problems homeless individuals experience with their feet are worsened when they also have diabetes. Progression of diabetes that is not managed can lead to nerve damage. This in turn can cause numbness and reduce sensitivity and feeling in the feet, increasing a risk for injury. Diabetes can also lower the amount of blood flow to your feet, and not having enough blood flow can make it hard for sores to heal, which can then develop into an infection that is also difficult to heal. Continued pressure or irritation could lead to a deep wound in the tissue called an ulcer. And in the worst cases, these deep tissue wounds can result in a prolonged infection that can lead to tissue death and a potential for the loss of a limb. For this reason, catching a cut or injury before it gets worse is very important. So some red flags to look for and ask your clients if they have noticed are asking them if they've noticed any changes in their legs or their feet. For example, are they experiencing any numbness, any tingling or pain in their legs or their feet? Another red flag is loss of sensation in the feet. So not being able to feel pain, heat, or cold. And again, the numbness, the tingling, and the decreased feeling are all signs of nerve damage that place the person at increased risk for injury. Other red flags include blisters or sores, deep tissue wounds, infected corns or ingrown toenails, dry, cracked skin on the feet, which are usually on the heels. And anytime you have a cut in your skin, this is a place for bacteria to enter and grow, leaving a person at risk for infection. So we want to prevent that. Um, Oh, sorry, I forgot to also mention that there are also fungal infections such as athlete's foot, and this usually happens or can be seen between the toes. This looks at like patches or deep breaks between the toes, and the skin may turn red and become really itchy. You may also see small blisters that break and leave exposed raw skin, so that's very painful. Their nails may also become thick and colored white or a cloudy yellow. So that's also something to keep an eye out for. So then what you can do primarily is check the client's feet and teach them what to look for. Again, this is more of the prevention. So I separated this into do's and don'ts. So you do want to encourage your client to check their feet daily for cuts, redness, swelling, sores, blisters, corns, calluses, or any other changes to their skin or their nails. You do want them to wear proper fitting shoes where the toes should have wiggle room. And as much as possible, try and keep the shoes, socks, and feet dry. Trimming the toenails straight across and gently smoothing out any sharp edges with a nail file. Moisturizing the feet to prevent cracking, and keeping the blood flowing by putting the feet up when sitting and wiggling their toes for a few minutes several times throughout the day. You also want to check that there are no pebbles, rocks, or any small objects inside the shoes. So before wearing them, make sure that you check there's nothing in there. And then moving on to the don'ts, don't forget to check the bottom of the feet, especially when the client is checking their own feet. As much as possible, don't go barefoot, as this really increases the chance that you may get a cut. And then definitely don't try and remove corns or calluses on your own, as this is very dangerous and can actually cause more harm. And then next steps for caring for existing wounds. So one of the most important things that can be done is to try and keep the wound clean and covered. So asking the client if this is something that they would like help with. It's also important to inform the client to avoid touching the wound and the wound base with their hands as much as possible. During any wound care, it's important to wash the affected area, and this can be done with soap and water. But if soap and water is not available, you could also carry a saline wound wash spray that you could use instead. So just anything to try and get the dirt out of the wound. And after the wound has been cleaned, it's okay to apply over-the-counter antibiotic ointments like Neosporin. So this is also something that you could carry with you. Additionally, you can also carry different size Band-Aids, gauze, and tape to help cover the wound. I think it would be beneficial to ask your client if they would like to keep any of these extra materials so that they can change them on their own if it falls or it gets really dirty. And then to help with dry or cracked skin, after cleaning it, you can apply petroleum jelly like Vaseline. Just avoid putting them between the toes, as this could create moisture that would actually lead to more skin breakdown. And it's okay to apply over-the-counter antifungal cream and powder to help with athlete's foot. So things you want to see in these open wounds would be a wound bed that is beefy red, as this is a sign that the wound is healing. Things that you don't want to see are increased depth of the wound. And the deeper the wound, the greater the need for medical evaluation. You also don't want to see a wound that is grayish or black. And here on this picture, I don't know if you can see me pointing to it, but the tip of the toe is an example of this dead tissue. So this is something that we don't want to see. Additionally, you don't want to see a wound that is dripping with pus, or that is bleeding, is swollen, or has a foul odor coming from it, as these are all signs of infection. And when needed, and if the client is willing, it would be appropriate to help the client schedule an appointment with their primary care provider or a podiatrist, especially when you notice that the wound is getting deeper or there are those signs of infections present, as the client may need medication, but again, asking them if this is something that they are interested in. When available, provide appropriately sized shoes and clean, dry socks, and encourage the clients to check their feet regularly and make sure that they understand good foot care practices. So that concludes my presentation. Thank you so much for paying attention. I can stop sharing the screen, and if anybody has any questions, I will try my best to answer.
I have all kinds of foot questions. Where did you go on my screen? There you are. First, thank you. Foot stuff really grosses me out. Those photos that you threw in there were fantastic, and I was really just like, but so it is a very common thing that we see in our clients is foot stuff, right? Like all kinds of foot stuff. And okay, one of my questions was, or is, okay, you mentioned that like diabetes can cause a lack of blood flow to the feet, which then I think you said maybe makes the feet more susceptible to wounds, or maybe because you can't feel them. Is that neuropathy? Is that what neuropathy is? Okay, so two-part question. One, can that be regained? So if we have a client who is maybe on medication for, we have a lot of people, I feel like on like gabapentin is the most common one for neuropathy. Can they regain the blood flow to their feet? And is that something that we should be encouraging, or kind of once that happens, they're kind of stuck with it? You know?
So this is to my best of my ability. I think that you can, but one of the main things, and I should have included it too, is that you really need to encourage like the blood glucose more, or like their sugar levels, to keep those like controlled, because when those aren't controlled, then it's really hard to regain any of the sensation or those feelings, because you're not getting to like the root of the problem. So I think like if you wanted to focus on something to tell the clients, it would be more about getting their blood sugar levels in like within a normal range.
Okay. And then for clients that are diagnosed with diabetes, maybe we know, if it's on outreach, sometimes it's harder because we don't get into a lot of that information, but sometimes they'll disclose that. Is it something that we should always be encouraging people, like if they have a diagnosis of diabetes, should it be like, have you seen either a specialist or like a podiatrist? I know we should always encourage to go see a medical provider, but is a podiatrist on that list of things that we should be advocating for them for? Yeah. Okay.
Yes, especially with like these more complications with diabetes, because even with like cutting the nails, you don't want to do it incorrectly where it will lead to like a cut in their toe, or because then again, that leads to a possibility for an infection to happen at that site. So podiatrist, and then they can also sometimes will give them like different shoes to wear, or socks that are more conducive to to manage diabetes and like the effects on their feet. So
okay, good to know. Thank you. Does anyone else have any specific? It could be about foot wounds, anything foot related. I know we all see it on a regular basis, so.
I got a question. Is it only more of a concern with foot care only to diabetic patients, or does that apply to all the patients, like with the high blood pressure and everything too? There's a concern only more for diabetes with foot care.
It would be to all patients, especially because with hypertension too, you also have these like problems with the blood flow. And so just a lot of this stuff, it's just prevention and to prevent any infection from like happening at all. So this is like in all patients.
If there are no other questions, going once, going twice. All right, Maria, you are off the hook. Thank you so much. And yes. All right, so next we have another exciting topic, infectious disease. And Jennifer is going to be presenting on that one. So Jennifer, I'll let you take it away.
All right, first of all, is it visible? Can everyone see? Not too small, not too big.
Perfect.
All right. So good afternoon. My name is Jennifer and I'll be presenting on infectious diseases. If at any point you have any questions, please type them out in the chat and either myself or one of my colleagues will address them at the end of the presentation. So to begin, I wish to provide an overview on different potential manners in which infectious diseases can be spread. Understanding these different routes provides you with the tools to subsequently be able to prevent these infectious diseases from continuing to spread. So I'll begin by going line by line explaining the different categories of infectious diseases. The first category we will be discussing will be diseases spread by touch, also known as contact diseases. These types of infections are spread by touching germs that are located on contaminated surfaces or items. For your reference, a common example of this for this category would be C. diff, which presents as diarrhea among patients. The next category would be contaminated food, also known as foodborne diseases. These types of infections are spread by individuals eating contaminated food and drinks that contain germs. Common examples of foodborne diseases include salmonella, norovirus, or Campylobacter. And again, this one would present as well as diarrhea. The next category is sprays and splashes, also known as droplet diseases. These infections are spread by an infected individual sneezing or coughing. This causes infected spit to be carried and spread out to other people. Common examples of droplet diseases include the flu and COVID-19. Next would be our inhalation diseases, also known as airborne diseases. The germs of these diseases survive and are subsequently carried in the air. So then another individual breathes in the infected air in that manner. Common examples of these diseases include TB and measles. Lastly would be our blood and Sharp's disease category, also known as bloodborne diseases. These infections are spread by infected blood entering an individual's punctured skin. Common examples of bloodborne diseases include HIV and hepatitis C. Now that we have an overarching view of the spread of diseases, I will be focusing on and discussing on the 4 highlighted disease examples for the remainder of the presentation. So just as recap, we will be discussing COVID-19, the flu, hepatitis C, and HIV. I wish to provide you all with sort of red flags and warning signs to be aware of among these infectious diseases. Identification of these red flags may indicate that the patient's condition has progressed and that they should seek medical attention. So we'll start off first with COVID-19. So some potential red flags to look out for if they have new chest pain, if they're having increased difficulty breathing, any new confusion, or if you notice that they're becoming pale, their skin is becoming pale or blue. So common areas to look out for would be mouth, or looking at the lips, around the mouth, and also for darker skin clients, it would be useful to look inside the mouth especially to see if there's any blue or paleness occurring. And then another useful areas to be looking for is fingertips to see if these are becoming blue, and just overall their skin and face, if there's any changes that they're increasingly more blue or pale. Now, with the flu, some red flags to look out for is seizure, if the patient is no longer peeing, if they have any severe weakness, any difficulty breathing, or any new pain occurring either in their chest, stomach, belly area. Now with hepatitis C, some red flags to look out for if they have black or tarry stool that can be a little bit sticky, if they have increasing yellowing of their eyes or overall their skin, if they have sudden confusion, or if they have an ongoing fever. Lastly, with HIV, some red flags to look out for if they have sudden weight loss, so if you notice that on them, or if they start verbalizing it to you, if they have ongoing diarrhea that's not controlled, memory loss, swollen lymph nodes, and also if they're having difficulty breathing. So with all of these infectious diseases, I would recommend posing these red flags as questions to your clients. That way you can gather a bit more information and to learn about these symptoms and to see if they're new or if it's an ongoing issue. So with COVID-19, specifically with chest pain, you can be asking the clients, are you experiencing any chest pain? Is it new? Have you felt that before? Do you have any difficulty breathing? Do you think it's getting worse? So it's just overall to track how far along they are in that infectious process. So next, I'll be discussing different interventions that you can all do to assist your clients. For all 4 of these diseases, the best manner to address the infection would be to seek treatment from a medical provider. But this option is not available for all clients. So I wanted to provide you all with different options that primarily focus on symptom management. So we'll start off with the flu. So I would recommend either giving Tylenol or Advil, depending on what's available, to help reduce any potential fevers that they may have, as well as introducing cough drops or throat sprays to alleviate any sore throats that may be experiencing, and just recommend adding more water and fluids to prevent any dehydration from occurring. Next, with COVID-19, similarly, again, recommending Tylenol or Advil to reduce any fevers. Again, increasing water and fluids to prevent dehydration. And also a useful tip would be if you do notice a client is having difficulty breathing, especially if they're slouching or to their side, try to help them sit up. Just being in an upright position really alleviates any difficulty breathing and makes it easier for them, just so they can in that moment be able to catch their breath. Next, with HIV, I would encourage increasing water and fluids, again, preventing dehydration, as well as encouraging oral care. So this can be brushing teeth, using mouthwash. With HIV, these patients are at increased risk of developing secondary infections. Primarily with HIV, that you can see yeast infections occurring in the mouth known as thrush. So in order to help decrease that risk, again, recommending to have them brush their teeth. Lastly, with hepatitis C, we would be increasing water and fluids, again, preventing dehydration. It can be a big issue in all 4 of these diseases, and as well as encouraging to either reduce or hopefully ultimately cut out alcohol if that is within their capacity. Hepatitis C can be very damaging to the liver, and having alcohol during that infection process can cause further damage to the liver. So just decreasing the amount of alcohol, if that's possible, will be best to prevent further damage from occurring. So alongside all these tools, I wanted to provide you all with knowledge on how to prevent these diseases. As mentioned earlier, a key factor in preventing these infections is understanding what category of disease they fall into. So for starters, flu and COVID-19 are under the sprays and splashes category. So these preventative measures focus on preventing or limiting exposure to any infected spit from other individuals. So preventative measures for both of these infections include either washing hands frequently and thoroughly for at least 20 seconds, maintaining a 6 feet distance from other individuals, and avoiding any individuals who may be sick or exhibiting any of these symptoms. And then lastly, with flu and COVID-19, I would recommend covering the mouth and nose with either mask, clothing, or cloth, anything possible just to create an extra barrier in front of their face. So HIV and hepatitis C are under the blood and sharps category. So these preventative measures focus on preventing infected blood from entering punctured skin. So specifically with HIV, preventative measures include encouraging condom use, encouraging clients to take PrEP, so which is pre-exposure prophylaxis medication, and that helps reduce HIV risk. And that would be before any sexual activity or if they are at higher risk. And then as well as encouraging usage of new or clean syringes. Next, some preventative measures specifically for hepatitis C, very similar to HIV. So it'd be encourage condom usage, encourage usage of new and clean syringes, and then overall avoiding sharing personal items such as razors and toothbrushes. With all of this, it's focused on preventing infected blood from entering an individual's body. But other than that, that would be the end of the presentation. So thank you. And here are some of the references I used throughout the presentation.
Thank you. Does anyone have questions for Jennifer about any of the infectious diseases? Yeah, there was a lot on this one I didn't know, so thank you. It was informative.
You know what, I just wanted to share, for all of us working in the field that, like with Hep C, you're not necessarily going to see those things, but you can, if that person is an IV drug user or was an IV drug user, or a little bit about them, like you can say, have you ever been tested for Hep C? Because usually you don't see people that are already jaundiced and the black tarry stools. It's pretty advanced at that point. But so it's important to just being able to ask that person, hey, have you been tested for Hep C, HIV, and as well as if they're IV drug users, the needle exchange program for clean syringes, as well as it's really important to educate on not sharing needles and this and that. So a couple of those things are important. Because it's Hep C, as you know, is very treatable now, easily treatable.
Mm-hmm. And I think that that's a good point, Eileen, because at the agency, we really are encouraging everybody to be handing out Narcan. And I think in that discussion as well, when we're asking people to not be afraid to ask if they're IV drug users, right? In whatever way you need to, right. You don't have to say, are you an IV drug user? But finding out if they are using needles to encourage them, like the use of clean needles, maybe they don't know about the needle exchange. And then to ask the question, have you been tested for HIV or Hep C?
Right.
Yeah, I think that's a good point.
I mean, with the Hep C, the point I wanted to make is that you're not most likely not going to see those symptoms that, people have Hep C, and that we can just encourage getting tested for it. I mean, it's certainly not just through IV drug use. There's all kinds of ways to get Hep C, tattoos, right. This and that, whatever. But, to just kind of encourage asking your client, hey, have you had that test? And so on and so forth.
Yeah. All right. Were there any other questions for Jennifer before we move on? Everyone's very quiet today. All right. Well, thank you, Jennifer. I appreciate that. I'm glad that's recorded. There was a lot of stuff in there that, and I don't know where I put it, but I wrote something down. Oh, the measles thing. I didn't know that measles was did it say airborne, or what did you call? I had no clue. I thought measles was another one that, you like touched or something. I mean, yeah, I had no idea. I don't know that. I mean, people get vaccinated these days, but I know not everybody does. And so fascinating. Okay. Enough about the measles. Thank you, Jennifer. Our next presentation is about urinary health, and it's Robert. Where are you, Robert? There you are. Take it away.
I'm going to be assisted by Maria, who's going to be controlling the PowerPoint. My name is Robert, and I'm a nursing student at UCLA, and the topic for this presentation is urinary tract infections, also known as UTIs. So a UTI is an infection of the urinary system, and that includes the kidneys, the bladder, or ureters. And while infections can affect any area of the urinary tract, the most common occur in the bladder. Next slide. So a brief overview of STIs. A UTI, I just answered that, I apologize. So one of the things that is really important with a UTI is that it needs to be treated early because it can become a kidney infection. As the bacteria goes up the urinary tract. So I put that in as well, just so that you could identify some of those symptoms. Risk factors that increase the ones, I'm sorry, I'm getting a little nervous. So factors that increase the risk of developing a UTI include being female. And the reason for that is that they have a shorter urethra than men. So the bacteria has a shorter distance to travel. Sexual activity, having new partners, having multiple partners is another risk factor. There's also certain types of birth control that it might increase the risk of developing a UTI. Anything that sort of changes the bacterial environment within the vagina could lead to a urinary tract infection. A suppressed immune system, diabetes, HIV, anything that affects the body's ability to fight infection, and any blockages in the urinary tract. So like kidney stones, anything that would trap the urine in the urinary tract increases the risk of developing a UTI. So for the next slide, we're going to look at some red flags. So symptoms of a bladder infection can include pain or burning while urinating, frequent urge to urinate, but maybe not voiding completely, burning, stinging pain, or feeling heavy in the lower belly. Another thing might be like a milky or unusual discharge, could be a sign. Symptoms of a kidney infection will include tiredness, fever, and chills, pain or pressure in the lower back or sides, and urine that smells bad or looks dark, cloudy, or red. And this is much more serious, as I said, condition. For the next slide, we have some interventions. The doctor will determine whether you have a UTI by doing several tests that include a urine test, giving you a physical examination if needed. And because it's caused by a bacteria, the way that it's treated is through antibiotics. Now, it's really important that when prescribed antibiotics that you complete the entire regimen, because the bacteria can develop a resistance against the medication that you're taking. So it's really important that you take it for the full 3 to 5 days or 7 days. And UTIs can also, sometimes they're difficult to diagnose because it could also seem like some sexually transmitted diseases. They have similar symptoms. And so therefore your doctor will make that determination based on the test results. Questions to ask clients is, does it burn when you pee? Do you have to pee more often than usual? Or does your pee smell differently or bad to you? Because those are probably the most common signs of a UTI. For the next slide, we'll look at some prevention. So ways to prevent UTIs would be to urinate after sexual activity, to stay hydrated and not to hold urine in when you have to go to the bathroom, don't wait. Take showers instead of baths, minimize douching sprays or powders in the genital area, and to wipe from front to back. That is my presentation.
Thank you, Robert.
I do.
And you did fantastic. I know you said you were nervous.
Oh, I got
it's nerve-wracking speaking in front of this many people. So you got the info out though. That's what matters.
I just, Katie.
Mhm.
Oh, can you hear me? Wait a minute. Something's happening here. I just wanted to mention, with UTIs, like what for everybody, for us out there assessing people. Well, if there's like, we have a lot of seniors out there on the street that are homeless. And if you see somebody that you may know that we've worked with and they're, all of a sudden they seem more confused, they're lost, they don't, they're saying things that are nonsensical, a lot of the time that delirium, UTIs in seniors presents with delirium. So that's something to take a look at also when you're, out there and assessing someone and they seem like all of a sudden the person you've known for a year or 2 years is like confused or something. And, and they're a senior, it could, the delirium is really common in UTIs and seniors. So that's something to be aware of as well.
It's good to know. I guess
the other thing, there was one other thing I wanted to mention.
No, go ahead.
Like where you were, the presentation was really good, by the way, and Robert, but also like pyelonephritis, which is a severe kidney infection, which can start from a UTI, but it can also, those symptoms of pyelonephritis, it can just skip the whole UTI and go straight to pyelonephritis, and you'll have a fever and chills and so on and so forth. So just those things to just be aware
of. What's hard about this one for me, the UTIs, because I know the whole idea behind the presenting the like this medical information for common ailments, and then for us as like case managers to be able to provide like a harm reduction approach, but with something, a lot of them you kind of almost can't, like with the UTI, it's one of those, if you let it go, the chances of it turning into a kidney infection and progressing are incredibly high. And so I think like that's the, my question was more around like trying to figure out, I mean, there's so many things that could be wrong with our clients, I mean, and us, but like specifically with our clients, that like knowing what to look for, I guess, or even ask, like, especially if we're just meeting somebody on outreach, or like a lot of times we get assigned new people that they're housed, but they're new to us on our caseload. And so we don't know. And so I think like so far, the three of you, the question really that I saw, or like what I saw in some of the PowerPoints was like, is this new for you? And I know that was my question to you all, like when you were showing me the PowerPoints before too, is like as case managers, really being able to be comfortable with like, if we see something that's a little, maybe off is not the right word, but a little off, that we are able to ask, is this new for you? And that's kind of like how we can dig into these kind of uncomfortable medical topics, especially as non-medical staff. So yeah, I appreciate it, because I know, Robert, this one is a little hard. You kind of can't go at it with the harm reduction approach. It has to be like, we need to get you on antibiotics.
Right. And you're not going to meet someone and say, oh, do you wipe from front to back?
Right. Good to know for personal though. But does anybody else have questions for Robert about UTIs?
Yeah, I was wondering how catheter usage can contribute to UTIs. I have a client that seems to have a perpetual UTI among other infections, but I'm just curious how I can assist them with that.
Catheters definitely increase the risk of UTIs. In fact, hospitals often talk about CAUTIs, which are catheter, oh my God.
I know what it is. I can't think of it.
Catheter-associated urinary tract.
Associated, that was the word, catheter-associated urinary tract infection. That's correct. Because you have a foreign object in an area where bacteria can develop. It's warm, it's wet, it's the perfect medium for bacterial growth. So yeah. I think there was a second part to your question, but
just like, is there anything, because he lives it, thankfully he's regularly seen in the doctor. Is there anything that like maybe a harm reduction approach, anything that can help them, like washing your hands, wearing gloves, that stuff
Well,
won't
yeah,
help?
I mean, hand hygiene, keeping it clean. I imagine that if he's at a facility that they go around like several times throughout the day to go and clean the catheter.
He does it himself at home, actually. He's
Oh,
in scattered site housing.
Got it. Yeah. Well, then it's all about hygiene and cleaning to make sure that no bacteria is introduced into the urinary tract.
Okay, thank you.
I don't know anything about this, but what does he clean, or what, I guess, should he be cleaning it with? Is it just regular soap and water? Or if he's not, I don't know him, so I don't know if he's someone that showers, but like, if he's not, is there, like, if someone has a catheter, we actually have folks on the street with catheters. Is there something else that they could use? Like even a wipe, is that good enough? I don't know. Like, can that prevent bacteria from going into their, in the catheter tube or however it gets up there?
Well, if they, you know what, if they're straight cathing themselves, where they're just, and when I say straight cath, they're putting the catheter in, they're draining, voiding, emptying their bladder, then they should, you know, it depends on their catheter supply. You could throw it out every time, but usually people don't have enough catheters to do that are on the street. So then they really need to, so what we could do if they were on the street is make sure they have a plastic bag to put the catheter in, that they're cleaning that catheter.
With soap and water?
Well, yeah, soap and water or vinegar and water is good. Or it's really hard, you know, to just, it's hard to avoid UTIs when you're catheterizing all the time. And then the people that have indwelling catheters, that, you know, they should have a primary care physician to go in and have that changed, you know, every month, 2 months.
Yeah,
Every month.
Yeah, to help with Robert, what he's saying with cleaning it in the hospital, what we do with patient who have the catheter that Eileen said is like indwelling catheter, where it stays in, where it's not being taken in and out. What you can tell the patient or like the client is if they have wipes, or usually we use a specific wipe, but if they don't, they can use soap and water, but clean at the tip of the hole, you can tell them. And then kind of like, instead of like, this is the catheter and this is the pee hole, instead of cleaning toward it, like clean like outward.
Away from it.
Away from
it. Okay.
Clean away from it. So you don't introduce any new bacteria going in. So that can be helpful for people who have to, like Raquel say, who have to do it themselves. You can just give them that.
That makes sense. Thank you. Were there other UTI related questions for Robert? All right. Thank you, Robert.
Thank you.
Last but not least, we have cognitive function. And we have Anaheeta doing the cognitive function.
Okay, so good afternoon, everyone. Can you see my screen?
Yeah.
Okay, great. So thank you so much for being here. My name is Anaheeta and I am a nursing student from UCLA, and today we'll be talking about cognition and memory loss. So just starting out with, what is it? So cognition is the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. And memory loss is an umbrella term for unusual forgetfulness. Memory loss makes it difficult for a person to make new memories or recall old ones. And what happens in memory loss is many times people begin to have gaps in their cognitive processes. So things that used to be very easy for them to comprehend and to kind of the way their brain works, all of a sudden there starts to be gaps. And it can cause difficulties in a person's life and their ability to function. And that's ultimately what we're talking about when we're discussing cognition and memory loss. So looking at who's at risk, it's not an exhaustive list, but this is kind of the most at risk. So those with a history of a head injury or an accident, people with uncontrolled medical conditions like diabetes, high cholesterol, or high blood pressure, people who are 65 and older, as well as people who are experiencing homelessness. And again, not an exhaustive list, but looking at what causes it. So dementia and Alzheimer's disease can be a cause. People who have had a traumatic brain injury, also known as a TBI. So this is an injury to the brain that can cause long-term effects and changes in their cognition. Alcohol and drug use, especially long-term use, can cause changes in memory. Side effects of different types of medications. And like Eileen was saying earlier, infections like a UTI. They could lead to delirium and different types of confusion that a patient might experience, as well as depression and anxiety. And I think an important thing to remember when we're looking at cognition and memory loss is that the reason for it can be very different depending on the type of impairment and the cause. So now looking at red flags. So some of the red flags that we see when a person is experiencing memory loss is they might start to misplace objects. So they might start putting things in unusual places, like their wallet in a bathroom cabinet or their dentures in a hat. They might start forgetting and mixing words. So they'll have what's known as word finding problems. So they'll call a wrench a turning tool because they won't be able to remember what the name of the turning tool is, but they know what it does. And that's again like a gap. They might also start losing track of dates, the seasons, as well as the time. They might have changes in mood and behavior. So social withdrawal, episodes of confusion, suspiciousness, and depression. They may begin repeating questions. So repeating the same question or information or asking the same questions. And this can also be reversed in the way that you can ask someone like, oh, have you had lunch? And they may say yes when they have not eaten all day, because they don't actually remember. And that would be a more severe form of memory loss, but it is something that is a sign of it. Another one is getting lost. So a person may have start forgetting learned information. So let's say they have a walking route that they normally follow or a driving route. And then as time goes on, they find that they can't find their way back home. And it a lot of times happens suddenly where like the person just gets lost. And that's kind of like the factor that makes the person have to get help for this. Another, or one of the last ones on this slide, is taking longer to complete tasks. So we might see that a person may have difficulty with activities that were once familiar. So the rules to a familiar game, or even if we look at more severe possibilities, they may have difficulty with remembering the steps to brushing their teeth, or the steps to putting on their clothes. And again, those are more severe forms. Again, it's the idea of kind of like forgetting things that used to be very almost instinctual. So now looking at what you can do. Okay, so this is the slide that I'd really like us all to focus on. So as case managers, you see people many times a week, and I really wanted to really pay attention to that because you might be seeing them a certain amount of times a week, certain amount of times a month. So these questions about alertness and orientation that I'm kind of going to go over can really serve as a go-to set of questions that you can use to assess a person's level of alertness and orientation that might give you a clue or kind of a sense of where they're at cognitively and in terms of memory loss. So just going over the questions, it's also known as ANO times 4. So you can ask the person the following 4 questions to assess their level of ANO, or alertness and orientation. So number 1, can you tell me your name? And if you can see the graphic to the left, you can see that. So if they can tell you their name, that would be oriented times 1. So they're oriented to person, they know their name. So can you tell me where we are right now? That would be oriented times 2. The person's now oriented to person and place. So they understand where they are. And then can you tell me what day, month, or year it is today? And that's oriented times 3. So that tells us that the person is oriented to not only their person, their place, but they're also oriented to time. So they're aware of the day, the date, the day of the week, and the season. And then the 4th one is, can you tell me what's happening right now and why we're here? So that really gives us a sense that the person can comprehend and explain why they're at wherever they're at, and they understand the situation. And for this one, there's no right or wrong answer. This is really an assessment tool. So you, when you're out in the field, can see, okay, I saw this person last week. How was their how oriented were they last week? Did they know what day it was when I asked them? Did they know where we were? But then this week, are they telling me that it's the year 1990, or are they telling me it's 2021? So when you're discussing them with another provider or somebody else, you can kind of let them know, yeah, the person knew what their name was, they knew what we were, but they didn't know what time it was, and they didn't know why we were there. And you can kind of get a sense, these don't necessarily have to be a structured type of thing. These are things you can also just kind of put into your conversation with the person. They don't have to be so structured, but the purpose of them like this is to kind of give you a structured way to know what you're looking for. So now looking at next steps. So next steps, once you've kind of looked over what a person's, you've assessed them, you know what their orientation is, and you see that, okay, they do think that it's 1990 and we need to get this person help. So what are we going to do next? So the next thing to do would be to assist in scheduling an appointment with the PCP, and really providing support and structure for a person and assisting them in scheduling that appointment, and also reorienting them back to what's going on right now. And in that process, you want to avoid criticizing or overcorrecting. So as case managers, I know you guys are 100% well aware of how this works, but just when the patient or when the client says, you know, oh, it's 1990, you can say, oh, it's actually 2021, and we're actually, you know, on Grand Avenue, and it's the middle of the day. Or actually, your name isn't Sarah, your name is Jenny. So just really giving a person a very gentle reminder of like what is going on right now. And sometimes that's enough to kind of help them get back to like where we're at in that moment. And it can be really helpful to the person. So it's important to be patient and supportive and let the person know that you're trying to understand what's going on. I also added the Alzheimer's Association 24-hour helpline because they have care consultants who can really help in terms of local programs and services. So if you do have a client that is really struggling with these things and you need really clear care for them, they're a really great resource to just reach out to because they're really trained on that information. And along with that, they don't diagnose, but in case you have someone who is diagnosed or you just want more information to help out your clients, they're a 24-hour helpline that can be really helpful. So let's say you scheduled the PCP, the primary care provider appointment. So the next process would be the physical exam and the diagnostics tests. So what they would expect during the exam would be first a check of the mental status. So they'll do more cognitive tests to see how the person's doing in terms of their memory. They then would do a primary care exam. So they'd go over the medical history. They'd see, did this person bump their head in the past? Does this person have a history of infection? They would do lab work to check, does this person have like a high level of something like a toxic medication that they're taking, that they're having like an adverse reaction to? So it's really about making sure that there's nothing going on in their body that might be affecting their memory. And then lastly, they would do diagnostic evaluations like a brain scan. So an MRI or a CT scan to see what's really going on in the brain on a physical level, to see if there's any way to find out more information. So really with memory loss and cognition, it's a lot about investigating and trying to support the patient in that investigation process. So that concludes my presentation, and thank you for listening.
Fantastic. Ooh, that was a fun echo. Well, I have a question. I'm just going to jump into my question. And then, so I know you had said, you know, like if somebody, you know, if someone asked me my name and I said, Melissa, and then as my case manager, you would say like, oh no, actually your name is Katie. And so my question is, when do we know like how far to go, I guess, when kind of questioning their reality, if you will? You know, like if I would be afraid of scaring the person, like we've had quite a few people with loss of cognition for all kinds of reasons. And maybe we were doing them, no service, right? Like by not questioning the reality, because it was just like, oh geez, like how do we tell him this is 2021 and not 1975? Or yeah, so I don't know, I guess I don't know if you can even answer that, or if that even made sense as a question, but how far do we go, I guess, in questioning their reality?
So I think, and anyone who has other things to say, please interject. But I think the way I see it is you're not trying to say I'm right and you're wrong. You're just trying to give like a gentle nudge to, hey, like, oh, so I thought your name was Sarah, or, most of the times we talk, your name is Sarah. I think your name is Sarah. And it's really like, you're not going to change that person's reality, but it's about kind of just nudging like, oh, I'm pretty sure today's date is, what is it, April 27th, 2021, but also not giving them a lot of stress about the date. Most people don't know the date. I mean, half the nurses in the hospital, when we ask that question, we don't know what the date is. So
Yes.
It's about being able to gauge like how serious of a question is this in terms of knowing their memory loss. So if it's like they don't know where they are and they don't know their name, then now you want to reorient them, but not saying like, this is your name. And like, if they would say their name is something different that day, that's okay. It's more of like an assessment thing. So you can take that to another provider or like to their PCP to say, hey, this person is not only doesn't know their name, but they're getting really agitated or stressed out over not of this whole process of being questioned about it, just so you know. So how can we help them to get to a place where they're not so, they don't feel like I'm attacking them by trying to correct their reality.
Okay, that makes sense and feels a little, I guess, easier, more gentle, I guess, because it is really hard. I mean, we have quite a few people, and it's really hard to witness somebody who has a home going through memory loss, not to mention like somebody on the street who it's like, how do you redirect them to home? I don't know, it's really hard. And just quick, because this is one of the most fascinating cases that I've worked with, and there's I think a few people still on here that worked with me on this one. We had a client who had really bad memory loss, and we had just started working with him. We started to like figure out that his name actually wasn't the name he gave us, and like we started doing some like detective work, which was fun. But so it was like, was it dementia? Was it this? Was it that? And yeah, Carol's throwing a heart up. She was one of the main detectives on this case. And, we got Venice Family Clinic involved, and Dr. King was like just super excited about this case because it was just so like odd in every way. And finally he thought, like, let's get him tested for, I forget what the actual first test was. And Carol, if you remember, hop on, but they ended up finding out through testing that he had neurosyphilis, it's like, people just don't really get diagnosed with that anymore, but he, who knows, got syphilis in like the 70s, I don't know, and then just let it go. And so it presented as, it looked like dementia. And then, but it was like, he had really bad headaches and his gait was off. And so it was like those little things that we all noticed, which again is like why questions are so important for people, like even as non-medical staff, like knowing what is, I guess, normal for this person and not, because if we didn't know, we wouldn't have been able to catch that. And thankfully, we worked with Venice Family Clinic. So they were able to take care of it. And, once he got treated, which was a horrific treatment, but his memory started coming back, and like, he took off and left us and went to go find his family. And so that was a good story, but I just wanted to share that because it was really fun. But yeah, if anyone has questions about cognition, or if you have a client who has memory issues, or, throw them her way. Or don't.
I have a question. It's been a while since I've worked with clients, but I'm thinking about a client that I worked with a few years ago who had a TBI, and he also was a very heavy alcohol user. And so it was really trying to help like come up with creative interventions to kind of help with memory and like remembering appointments. And like a big thing was like, he also had these like seizures. And so like he had medication that he needed to take like every day to ensure like he wouldn't just pass out in the middle of, you know, the day or night. So I'm curious if you have any like proposed interventions you would suggest for like folks who are having cognitive issues and are also potentially dealing with substance use on top of that, and trying to really support them with like, you know, reminders and like taking medication and kind of just like those basic day-to-day things that's like, we're not only dealing with a medical condition, but we're also dealing with substances now kind of being in the mix of all that.
Yeah, absolutely. Because it's like you're not only dealing with the memory, but it's a chronic condition. And there's like more than one chronic condition going on. You know, in the research that I did, a lot of it had to do with creating structure for the person. And especially when someone has alcohol use, like it can lead to things like Korsakoff syndrome is a type of memory loss that is caused by like heavy alcohol use for long terms of, so that might have been something that he was dealing with too. I think that a lot of it is about structure. So writing things down, reminders, Post-its, putting them in places that he knows, creating a routine. I highly recommend, I think the Alzheimer's helpline, that I really feel like they probably have a wealth of knowledge because they're so well funded. And I unfortunately don't have that information at like the tip of my fingers, but I do think it's really important to creating an environment that creates success for him. And that would be like the Post-its, maybe even on his, I don't know if he's housed like on a refrigerator or on the door, writing like, before you leave, did you do this? Did you do that? So checklists, things like that can really help, because it really provides support. Even like maybe check-ins on a weekly basis, on a daily basis, things like that just come to mind. If anyone else has any other things that come to mind, please chime in.
That was really good, just what you were saying. I mean, we have somebody here at Turning Point who has, you know, kind of the same issues. And it's just getting that routine going and just enforcing it. You know, whether if he has meds at bedtime, you know, but the staff here can offer him his meds, but he knows to go to the office, or like he has an Advair inhaler, you know, the purple one that I don't know if you guys know which one I'm talking about, but we made a video for the staff to show the staff how to use it so they could help him with it, because he can't remember how to use the Advair inhaler. But it's just routine, constantly, you know, getting into a routine. Like even like he'll drink like a half pint every day morning. So it's like, even before you drink your half pint, come hit me up for your seizure meds, you know. And just getting in that routine is what helps. It's hard. It's very challenging though.
Yeah, thank you. That was really helpful. I think it was a little bit easier, and I use that really lightly because he was housed. And I think we pose an even more unique challenge when clients are on the street and their encampment and locations can change. And so I do think it's not impossible, but it does make it hard to get that structure and flow and routine until they're at least inside, there's eyes on them, and there's at least other people around that can be more instrumental in that day-to-day. So thank you.
Were there any more questions? Okay. Well then, I want to say thank you to the 4 of you who presented today, and thank you everyone who, you know, took an hour and however many minutes out of your day to come check in and you know, learn some stuff about health needs. There's a couple more of these. We might try some breakout rooms and activities in the other ones if I can convince the nurses to, but or figure out how to do it on here. I don't even know. But yeah, so I'll send out, actually the agency sent out kind of like a blast email. So the Zoom links are in there. And yeah, we'll stick around for a few minutes. If anybody has questions and just doesn't want to ask the large group, that's fine too. We'll be here for a few minutes. Otherwise, thank you all so much for coming.
Thank you.
That was great. I really loved it.
Good job, y'all.
You guys did fantastic. You really did. Awesome. Way to
That
go,
was
Katie.
awesome. You know what I
It was
did?
really good.
Yeah.